if I can get them going here. All right. As everyone's coming in, we have about 2 minutes before we're going to get started. There's some housekeeping slides that'll be flipping by, and I'll make a couple of brief announcements and then we'll get started. As everyone's joining us, welcome to this session. We're going to get started in about 1 minute. We have a few housekeeping slides that are going by, and then we'll get started. Thanks for joining. Okay, a couple of quick housekeeping notes as we're getting started here. First, today at 3 p.m. Eastern, visit our exhibitors in their individual exhibit booth Zoom meeting rooms. Look at the sponsor tab in the navigation bar and then click on Virtual Exhibit Hall. Come by and meet the sponsors who support our conference. At 3:30 Eastern, immediately after that, there's a Careers and WASH virtual networking event for young professionals, happy hour and networking in one event. And tomorrow, the last poster presentation session begins at, I said they were going to be manual, there we go. Begins at 3:15 Eastern time. There's posters, and take the opportunity to talk with presenters in individual Zoom meeting rooms. Look for the agenda tab at the top of your Pathable screen and then find the all posters option. Okay, now we're going to move on to the verbal presentations. Okay. So we are joined by 3 very qualified, very interesting presenters today on this theme of culture and diversity. I hope all of you were able to catch the plenary earlier today. If you weren't, I very much recommend it. I think that this session follows on very naturally from that. Without further ado, we're going to start off with our presenters. We'll start off first with Julie Hennegan. She is a research fellow, was at the Johns Hopkins Bloomberg School of Public Health and at the Burnett Institute. And she's going to be talking today about menstrual health at work among adult women in Mukono, Uganda, a mixed methods exploration. Julie, over to you.
Thanks, Ben. All right, just going to share my screen. You can see that? Yeah? Okay. Good morning, good afternoon, good evening, wherever you are. I'm coming to you from Brisbane, Australia at 4 a.m. So I'm hopeful that I'm going to be able to string this presentation together for you. Despite the time, I'm really excited to be able to share some of our findings from this study about women's menstrual experiences at work in Mukono district. As many of you may be aware, much of the attention in menstrual health research and practice has been on the experiences and needs of adolescent girls. But menstruation continues over the life course, and there's been a lot less emphasis on what this means for adult women, particularly at work. And workplaces are really important environments. They're a place where working women spend a significant proportion of their day, And they represent sites of opportunity for income, for improved living standards, autonomy and health for women and their families. But they can also be sites of compromised human rights, health, and well-being. So in this study, we set out to understand, firstly, how women manage and experience their menstruation and sanitation needs at work. And secondly, how unmet menstrual needs influence women's work and health and well-being at work. The overarching project looked at both experiences of sanitation more broadly and specifically at menstrual experiences. My colleague Natalie Exum presented in the previous session about some of the findings related to sanitation. So in this presentation, I'm going to focus on experiences of menstruation. We took an exploratory mixed methods approach in this study, and we focused primarily on women working in markets in Mukono, Uganda, with the addition of a small sample of women who were working in healthcare facilities and government primary day schools. We worked with the local government to identify all eligible markets within the district, and then we sampled the healthcare facilities and schools in closest geographical proximity up to the point where we achieved our pre-specified sample sizes. In the first qualitative phase of the study, we undertook in-depth interviews with 35 women, aiming to understand their experiences and needs. And we sampled purposefully for diversity across age groups and a range of different work characteristics. This then informed a quantitative survey where we could capture the experiences of a broader set of women and explore the relationships between the environment, unmet menstrual needs, and impacts on health and work. Our quantitative survey used a systematic sampling approach, and we sampled proportionately to the estimated number of women working in each market. We then also planned, and we still plan now, to go back to communities and share our findings and prioritize next steps with them. We haven't been able to do that yet due to the COVID restrictions that essentially started right after we finished our survey. So what did we find? Well, I've got limited time today, so I'm going to touch mostly on some of our qualitative findings with some additional description from the quantitative survey. In our qualitative analysis, we found that women's experiences were really underpinned by a very strong social expectation that an adult woman should be capable of managing her period without any assistance. Struggling to manage menstruation, this is something that was acceptable for adolescent girls, but for an adult, failing to manage and carry on with usual activities during menstruation really represented a failure of your womanhood. This overwhelmingly shaped women's experiences because this ideal needed to be upheld, regardless of the sanitation facilities or costs or discomforts to the woman. Behaving responsibly as an adult woman meant keeping menstruation a secret. So not talking to anyone about it and not letting anyone see signs that you may be menstruating. There was an exception, though, to this code of secrecy, and this was around menstrual challenges that were viewed as medical. So intensive pain, heavy bleeding, or changes related to contraceptive use. For these particular concerns, women were viewed as needing to seek advice, particularly from healthcare providers. And this was echoed in our quantitative survey as well, where 86% of women reported that they would be comfortable discussing menstruation with a healthcare provider, whereas only half would feel comfortable talking about menstruation with another woman at work, and a similar proportion had someone that they could ask for support related to their period. Menstruation, and by extension a menstruating woman, was viewed as unclean. Women expressed personalized and very authoritative views about what it meant to maintain hygiene during menstruation. Even though the practices and these sort of expectations differed from woman to woman, each believed that this was the standard that needed to be applied to all women. Cleanliness was required both to maintain hygiene and to avoid infection and odor, which were really significant concerns for women. And it was also needed so that women could feel comfortable at work. There's too much to unpack in the time we have in terms of women's menstrual management and the workplace facilities, but just to flag, the sanitation conditions really vary quite widely across the markets and changed women's management practices. You can see on the slide the very variable proportions of women who traveled all the way home to change their menstrual materials, depending on what market they were working in. In our remaining time, I want to talk quickly about the consequences that we found women experienced. Women certainly did report missing work due to menstruation, and this was about 20% in our quantitative surveys and similar to what we'd heard in the qualitative interviews. Menstrual pain was the most common reason for missing work, although over 40% of women in our surveys who had reported missing work included concerns related to menstrual management as one of their reasons for missing work. For women in markets who miss work, this also incurred financial stresses, consequences due to missing customers, and many other women simply couldn't afford to be absent, either because that meant that they wouldn't make enough money to survive or because their boss wouldn't allow it. And so as a result, many endured really significant consequences for their well-being in order to remain at work. Menstrual involved financial costs and stresses beyond this. There was the cost of menstrual materials. For many women, pads were expensive, but they were also often something that women felt was worth paying for, so they saved for and prioritized buying. Other women, some believe this was the only acceptable material, where others mitigated some of the cost of pads with other materials like cloth when they were at home. And menstrual materials weren't the only costs. In many workplaces, women had to pay to use the sanitation facilities, meaning that they incurred cost for each time they had to change or going to wash their genitals, which for most of the women in our study was an essential hygiene behavior. Women really vigilantly monitored their cleanliness and risk of soiling during menstruation. And the extent of this worry really varied quite a lot, depending on women's confidence in her own management behaviors, the amount of pain or heavy bleeding she had, the workplace resources, and her own access to social supports. And experiences really ranged from sort of constant anxiety and never having peace during that time to women who felt more free and easy. For women, menstruating at work was also characterized by a lot of physical discomfort, not just enduring menstrual pain, but also not feeling clean and positioning the body in such a way that the risk of soiling was minimized, so standing for really long portions of the day. I think illustrative in our quantitative survey, although 20% of women in markets miss work during menstruation, almost half would rather miss work during their period if it was possible. So in sum, we found that in Mukono, Uganda, menstruation certainly does impact the work, health, and well-being of many women. In seeking to support women, I think it's really important that we take a holistic view of menstrual health. Being at work is not enough if women are enduring significant pain and distress or discomfort to be there. We also found that gendered expectations surrounding menstruation are really critical to understand. The need to behave as a responsible woman from the view of our research team placed really intense expectations on women that resulted in harms for them. But from women's perspective, this was a necessary ideal. It was something that they felt pride in enacting and judged other women really harshly for failing to meet. I think this has implications for our menstrual health advocacy and programming, even with regards to adolescent girls. On the one hand, when we emphasize challenges for adolescent girls, I wonder how we feed into the narrative about the way that adult women should experience and manage menstruation. At the same time, in our attention to reducing stigma and silence around menstruation and attention to female-friendly sanitation infrastructure, we have the potential to benefit not only girls, but menstruators over their life course. Quickly, menstrual pain and symptoms were a significant concern, and women did engage with healthcare providers in this sample, but it wasn't really clear the extent to which this really resolved or helped with their concerns. There was a lot of variable information about hygiene requirements, infection and pain management, but we also think that healthcare providers present a real opportunity. They're a support source that women are already engaging with and are comfortable talking to, and so might be a key group to provide information and support. The cost of materials and sanitations were really significant burdens. And women talked a lot about the quality of different menstrual materials and the pads on the market and their concerns about them. They really wanted to be engaged consumers. And we had limited scope for discussion, but obviously the workplace sanitation conditions are also really key. So thank you. Just to flag, our qualitative findings at least should be available really soon. And I'm happy to answer any questions. I think, Ben, you're gonna have a look at the chat.
Yes, thank you very much, Julie. I'm gonna just relay a few questions here. We have about 3 minutes. So first from Sylvia, did women manage non-menstruation related bleeding, like from PCOS, differently?
No, well, I mean, managing bleeding was related to managing bleeding. So I don't think that women really separated between different bleeding types. You know, if they were using a contraceptive, they would still talk about it as menstrual bleeding. If that was irregular, that's frustrating. We had some quantitative questions around that as well in the survey. And we didn't hear a lot about sort of spotting or other breakthrough bleeding. It was a lot more about sort of more regular menstrual bleeding.
Okay. From Lisa, she asked, did you get any sense of the factors that resulted in such large differences in women going home from various markets to manage menstruation?
So there were really different sanitation conditions. I think there were a couple of markets where women were, and Natalie might have spoken about this as well, more leveraging, you know, going to neighbors' places and maybe not feeling comfortable managing their period there. There were a few where the doors were really inadequate in the sanitation facilities. And this tended to be the markets where the sanitation facilities were free. They were more poorly maintained, and the doors often weren't working very well, or they were very dirty, and so women just didn't want to use them at all. Whereas in other markets, you know, they felt that they were reasonably well maintained, but they had to pay. So it was a little bit of a trade-off in terms of the conditions, and then I think whether or not women were willing to use that space for menstrual management and for other sanitation needs.
Okay. And one last question from Leandra. You mentioned the cost of menstrual products. Do you know what access to these products was like in this setting?
Quite reasonable. So this was an urban setting, and women pads were available within markets within the district. So it wasn't so much an issue of accessing to the pads, and we had a proportion, I think it was 8%, but quite a few women in the qualitative study also talked about reusable pads. It was more that they were very concerned that cheaper brand pads were either not fit for purpose or were burning, or they were worried about consequences. So women were often spending more on more expensive, you know, sort of brand name products, believing that these were higher quality, and they may well be. I mean, we were quite interested that there was a lot of different, you know, consistent reports about the behavior of different brands, and that, you know, women did also have a lot of concerns around the quality of the product and wanted more information, so they could be really, you know, informed consumers of these products. But access to them wasn't the issue. It was more around cost.
Okay. Great, thank you so much, Julie. There are a few more questions in the chat box that you can respond to there afterwards if you'd like, and please feel free to keep putting questions there, everyone. I'm going to turn over now to Jay Kwong, who's going to be presenting Women Are More Sensitive to Perceived Social Sanctions Related to Open Defecation, Evidence from Tamil Nadu, and she's from University of Pennsylvania. Jay, whenever you're ready.
Thanks, Ben. Good afternoon, good morning, good evening, everyone. Thanks for coming to this session. My name is Jane Kwan, and I am a PhD student in psychology at the University of Pennsylvania. So in this presentation, I would like to talk about our study in Tamil Nadu, India, primarily focus on people's perception of social sanction and social norms related to defecation behaviors. So first, I will discuss the type of social sanctions and then the relationship between perceived risk of sanctions and the social norms. And finally, I will discuss the gender differences in this relationship. So what is social sanction? A social sanction is a social reaction of approval or disapproval in response to someone's actions. Social sanction can be classified in these two-dimensional spaces. As you may say from the definition, positive sanction is an action that rewards a particular behavior, which usually indicate others' approval, while negative sanction is a threat or punishment, which usually indicate others' disapproval. Along the formal and informal dimensions, we could just understand it by this literal meaning. The formal sanction suggests the reward or punishment usually coming from an institution such as a company or a school, while on the informal section is an official form of sanction that usually comes from friends, neighbors, or families. So here I'm using the section in a workplace as an example. So the formal section includes receive promotion from work or, for example, getting fired from a job. And the informal section could include receive the prize from colleagues or the gossip among colleagues. So in our study, we're mainly interested in the negative section related to defecation. In this case, the formal negative section could be a fine from village officials, and the informal negative section could be a gossip among neighbors. So to simplify, I will use sanction as a short for negative section through the rest of this talk. So the recent lab study find that individuals' propensity to sanction someone who deviating from the norm is related to the prevalence of the desirable behaviors. Specifically, when a social desirable behavior becomes more prevalent among a social group, group members consider the deviators more punishable. The effect of commonness on the willingness to sanction someone can be explained by the social impact theories. So according to this model, as more people becoming the source of the influence, their impacts, such as the peer pressures on the individual target, increases. So in this case, as more people behave in what is judged as socially desirable way, perceived peer pressures on the deviator intensifies. Another view offers explanations of the association between perceived prevalence of behaviors and the likelihood of perceiving the risk of sanction is norm internalization. According to norm internalization, when a behavior is commonly practiced and approved by members of a social groups, the norm may be internalized as moral, and the norm abandoning behavior will be considered as good or appropriate. So consequently, people expect informal external sanction, such as shaming or gossiping, or experiencing internal ones, such as guilt or shame, when they're deviating from the norms. So taking those two perspectives together, we'd expect to observe when an individual perceive more people engaging in a socially desirable behavior, for example, in this case, toilet use, they will be more likely to perceive the risk of sanction for deviating from this norm. In this case, will be open defecation. Actually, social sanction was closely related to sanitation. Some forms of social sanction, such as peer monitoring and shaming, has been incorporated in behavioral change program to promote toilet use in India. So these include both national program, such as Clean India Mission, or community level program, such as CLTS. This intervention has proven to be very powerful in enforcing the positive norms by deterring individuals from engaging in the undesirable behaviors. However, such social components may potentially inducing psychosocial stress, such as shame, guilt, and fear, which might disproportionately affect women. So there's a growing field evidence women's sanitation insecurity has showed that OD practice are related to increased psychosocial stress due to their decreased privacy, increased risk of sexual harassment, and the risk of social sanction, such as gossip and worry of a disapproval from their families and community members. So as we see, toilet use becomes more and more prevalent under the national and regional initiatives, it might further intensify the psychosocial stress among women who still lack of adequate access to toilet. Indeed, the gender difference has been noted in both perceived risk of sanction and conformity in the previous study. Literatures on the deterrence effect suggest that women tend to be perceiving a higher risk of sanction, including shame and embarrassment than men. Women are also more sensitive to social influence, including the peer pressure associated with deviating from the common behaviors of their social groups. So therefore, we'd expect to observe a gender difference in the relationship between perceived risk of social sanction for OD and prevalence of toilet use in our study context. Specifically, we'd expect this relationship is likely to be stronger for women and then for men. So to quantitatively testing this hypothesis, we use cross-sectional data from the longitudinal evaluation of norms and network study. LENS is an ongoing cluster randomized trial in peri-urban communities of Tamil Nadu, India. This trial aimed to improve toilet use and maintenance through a norm-centric approach. So for this study, we used the baseline data collected from January to March 2020. A total of 2,427 respondents from 75 communities provided the valid responses to our survey. So here we use census ward as a proxy for community. So the average age of the respondent was 45 years old, ranging from 18 to 98. Among the surveyed respondents, 53% are women, 98% are Hindu, 81% have access to the type of toilets, and 75% reported using the toilet primarily in the 2 days before the survey. To answer our first research question, what are the common forms of social sanction related to open defecation? We conducted a household survey. So field workers first asked respondents whether they perceive a risk of sanction for OD. If their response is yes, we further ask about the type of social sanction. So the options are developed based on our previous study with the open-ended question, as well as previous literatures social sanction related to open defecation, which include both informal sanction as well as formal sanction. We found that majority perceive social sanction related to open defecation. Among those, verbal reprimands was the most common form of social sanctions, followed by advice and gossip. So this evidence suggests that majority perceive an informal social sanction related to OD. Then we want to understand how perceived risk of sanction for OD is associated with the prevalence of the toilet use. To measure the perceived prevalence of toilet use, we asked respondents, think about 10 members of your community. Out of them, how many do you think use the toilet every time to defecate? The answer ranged from 0 to 10, where 0 represents not prevalent at all, and 10 represent extremely prevalent. We found those who perceived toilet use as more prevalent in their community were more likely to perceive the risk of social sanction for OD, which is consistent with our hypothesis. We also find who primarily used toilet in the last 2 days before survey were more likely to perceive the risk of a social sanction for OD. Compared to men, women are almost twice likely to perceive the risk of a social sanction for OD. And the third question is, are women more sensitive to perceive the risk of social sanction when they perceive more people are using the toilet? To answer this question, we did a moderation analysis, and we found, as predicted, the positive association between perceived prevalence of toilet use and perceived the risk of sanction for open defecation is significant among women, but attenuated among men. So to summarize our finding, we observed that majority perceive risk of informal social sanction related to open defecation. Second, people were more likely to expect social sanction for open defecation when they believe that toilet use becoming more prevalent in their community. And third, this relationship is stronger for women than for men. Our finding contributes to the growing literatures on women's sanitation insecurity. In particular, the psychosocial stress that disproportionately impact women. So the literature showed that women are vulnerable to experience fear and worry of disapproval from their community members for open defecation. In India, it is often considered as a dishonor to one's family if women are seen practicing OD. Having to defecate in the open could indicate an absence or inadequate access to sanitation facility, which has overarching impacts on women's sanitation across life stages. So this negative experience, both external, such as shaming or gossip, as well as internal, such as guilt or shame, may have a long-term impact on the mental health and well-being of women. So therefore, our finding emphasized the need to improve toilet access for women, especially given the changing scheme of national and regional initiatives, which gradually shifting the norm from open defecation to toilet use in these communities. Practitioners and policymakers that aim to promote beneficial behavior, such as toilet use, should consider potential psychosocial stressors and take a gendered approach, especially when this intervention seek to include social influence and social sanctions as a motivator for behavior change. So rather than using the negative informal social sanction, such as shaming and social exclusion as a motivator, people might consider using the positive social informal sanction as a motivator, such as the prize or social recognition. Finally, I would like to thank for our collaborator who provide valuable insight to this study, our funding agency, and our data collection partners, and all of the participants who volunteered their time in this study. Further details related to this study can be found in our recent publication M+1. I also upload the papers to the file section. Thank you very much for your interest in our study. Please feel free to leave your comments and questions in the chat section.
Thank you very much, Jai. We have just about 1 minute here for questions, but please continue to put your questions in the chat, and Jai can respond to those afterwards as well. So first from Anna Ellis, she asked, did you measure whether social sanction came from same or different gender, or I would add to that from different other sorts of demographic differences, different groups?
Yeah, so when we're measuring the social sanctions, we're asking the open-ended question initially, and then we have two independent coders to code what are the most common forms. And then in this survey, we're doing the multiple choice. As your question about people from different demographic groups, we include those factors in our regression analysis. Let me show the slide back. As here, we include people's primary defecation behaviors, age, racial status, and their socioeconomic status, and caste, as well as their education. We do see there are some differences across the demographic groups.
Okay, thank you very much. We're out of time for this presentation, but there's a few more questions in the Pathable chat. JE, if you can address some of those, and others, please continue to put your questions there. We're going to move now to our third presentation. So Guy Norman, who is the lead consultant and managing director for urban research, is presenting on basic service improvement in slums. What would residents prioritize? Guy, over to you.
Great. Can you see my screen, Ben?
Yes.
Okay, thank you. And hello to everybody everywhere. My name's Guy Norman. I'm going to talk to you about a piece of research we did in 2019 under WASUP's Urban Sanitation Research Initiative. It's me presenting, but of course this was a wider team, and I will give a shout out to my colleagues at the end. So moving to, bear with me. Moving to the first slide. The aims of the study. The central aim of the study was to assess how slum dwellers, in inverted commas, in Accra, in Ghana, and Nairobi, in Kenya, prioritize different basic services, by which we mean things like water supply, healthcare, street paving, etc. And we also wanted to understand the extent to which prioritizations vary among and within cities. And we hope to explore whether prioritizations are associated with possible predictors, which might include the current service level, the respondent gender, and tenure status. I wanted to leap straight in with the list of services we considered. Now, this was a list of 17 services, which we drew up ourselves on the basis of literature review and our own analysis, and then sense-checked and somewhat modified through focus groups and interviews with key respondents in Kenya, in Ghana, for example, municipal planners. It's there, the list is there presented in alphabetical order, but as we'll see, we didn't present this list to respondents in alphabetical order. Very briefly, running through our methods, as in many studies of this type, we started with a qualitative phase and progressed into a quantitative phase. In the initial qualitative phase, we ran focus groups in selected slum communities in Accra, in Nairobi, and we carried out expert respondent interviews with people, including municipal planners. Having carried out the qualitative phase, this then provided a basis for survey design and questionnaire design. We then carried out household surveys across a wide range of slum communities in each of those two cities, Accra, Nairobi. About 3,000 respondents per city, which is a large sample size. And the advantage of that is that in addition to the city level, it allowed us to characterize about eight sub areas within each city. I note that we interpreted slum in a deliberately broad way, including extreme slums but also more moderate situations. And we used an approach called systematic spatial sampling, which I won't go into now. The questionnaire, as you can imagine, had these sections, but I'm going to leap straight into section 5, around basic services, which is the focus of this presentation. We presented the 17 services to respondents not as a tedious written list. Rather, we designed and printed 17 cards, one representing each service. Only 10 are shown in the photo, but of course the respondents were shown the full 17. And I wanted to focus on the key questions within the questionnaire around basic services. Firstly, we asked each respondent to put the cards into 4 groups, considering whether you judge current service level to be good or adequate or poor or non-existent. And I will come back to this as perceived current service level. We then asked, if the authorities were to invest money in this community, which 5 services do you think should be prioritized? Let me just say before I start with the findings that although this research was delivered by WASUP, which is a water and sanitation organization, I want to stress that we did not set out to demonstrate the importance of water and sanitation, and we took pretty strong measures to avoid bias, some of which you can see on the slide. Moving to the findings, and at the very simple top line level, the services most frequently included in the top 5 priorities in Accra were flood control, which was placed in the top 5 by 50% of respondents, garbage removal, housing quality, sanitation, and social care. If we now compare that with Nairobi, we see that in Nairobi, the services most frequently included in the top 5 were sanitation, again, street paving, water supply, environment, and again, as in Accra, garbage removal. So if we compare these situations, we can see that there were 2 services which were highly prioritized in both cities, sanitation and garbage removal. Other services and areas, types of environmental improvement were specific to each city. And of course, this is what we would expect. We would expect different cities to have different issues. As noted at the beginning, we did consider within city variation. I don't have time to consider that in depth now, but here we see at the top the list of 17 services in Accra and the average prioritization rating of those services. And as you can see, the tallest bar is flood control. And below that, we can see area-specific results, the same graphic for the 8 sub-areas we included within Accra. I don't have time to go into this, but what I can say is that the broad shape of those graphs is pretty similar across all of those areas, and we have observed a similar pattern in Nairobi. That, of course, is not to say that there is not variation within cities. This graph shows average prioritization of the 17 services down the left, and that's in blue, against perceived level of service for that service. So if we look at sanitation, for example, that's the most highly rated, and in fact the perceived service level is fairly high for sanitation. What we do see in this graphic, and you'll see that it's ranked from top priority to lowest priority service, what we do see is some possible evidence of a negative association. So to explore this, we used logistic regression to assess whether there are statistical associations between service prioritizations and other respondent household variables, including perception of current service level, poverty level, and gender. If you wish to understand the analysis in more detail, there's a little bit more information on the slide. For most services, we found that people who rated the current level of that service as less than good were more likely to prioritize that service. And this is, of course, the intuitive expectation. For example, with street paving in Accra, if we compare with respondents who rated the current situation as good, Respondents who rated as adequate were about 5 times more likely to prioritize. Respondents rating as poor, about 46 times more likely to prioritize. And respondents rating as non-existent, about 51 times more likely to prioritize. Now, 46 and 51 are very big odds ratios. So this does indeed indicate a strong association. The full findings of our association analysis are way too complex for me to describe here, but I wanted to make some brief remarks. And the first is that respondent gender showed surprisingly few strong associations. For example, there was no association between respondent gender and prioritization of healthcare. And certainly women and men were both well represented in our samples. And very briefly, for many services, counterintuitively, people who rated current service level of service X as poor prioritize that service more highly than people who rated current level of that service as non-existent. Very briefly stating our conclusions, the sanitation and garbage removal were among the 5 most frequently prioritized services in both Accra and Nairobi. Water supply was among the 5 most frequently prioritized in Nairobi, but not in Accra. And indeed in Accra, it was on average rated 16th of 17 services, so way down the list. Other highly prioritized services included flood control, housing quality, social care in Accra, street paving, and environment in Nairobi. But as I say on the side, this certainly does not mean that the lower prioritized services, the remaining of the list of 17, are unimportant, and we don't want our research to suggest that. Very briefly, considering the wider implications of this research, we would say that systematic studies of this type can be of value for informing urban planning at the city level. Community prioritization of services is not the only factor in investment decision making, but it's an important factor. Secondly, if studies of this type were extended across a wider sample of cities, it seems that more generalizable conclusions might emerge. And I do note that we initially intended to deliver this research in Dhaka in Bangladesh as well, but unfortunately we didn't get ethical authorization in time. Finally, I wanted to point out that a multi-services perspective of this type ties to the view that urban water and sanitation improvement shouldn't be expected to impact on health and well-being in isolation. Now, this is not an empirical finding of this research, of course, but I think the two concepts are related. That's it from me. My colleagues involved in delivering this research, designing and delivering this research, are listed here. I want to particularly shout out Nerea Goa, who made very significant inputs, and thank colleagues from the University of Santiago de Compostela in Spain who supported us with the statistical analysis. Any questions, please see the emails on the slide. Thank you.
Thank you so much, Guy, and thank you for the great presentation. I'll remind our attendees, if you want to pop questions in the chat on Pathable, please do so, and I'll moderate and read those out to Guy. I don't see anyone that's done one yet, so I'm going to selfishly take the first one, Guy. This is fascinating to me. I'm interested in how these different types of service relate to each other in terms of, say, the costliness to deliver. Like how would a policymaker evaluate these user preferences compared to, you know, their finite amount of resources to assign? Does that make sense?
Absolutely. I don't want to give an answer to that because this was beyond the scope of the present study. We did not in any sense look at the costs of delivery or of improving these different services, but I absolutely agree. In any application of findings of this type in urban planning, urban investment decisions, then it would of course be necessary to consider the costs of different investment. Okay.
Let's see. Sorry, things are popping in the chat quickly enough that I'm trying to read one and the next one scrolls by. Let's see. So a question from Anvesh. Could you explain the thought that went into making these 17 services, the ones you selected? How would they change if you extended the study to a wider range of cities?
Yeah, so we paid attention to this. We, as I said, we created the list on the basis of literature review and our own brainstorming analysis, but we did then take this list to Accra, or an earlier version of this list. We took it to Accra, we took it to Nairobi, and we, rather surprisingly to us, we found that both focus groups and expert respondents made few changes to this. There are elements of the list which seem quite culturally determined. So, for example, we expected environmental quality, clean rivers, public spaces to be quite culturally specific, and we expected to see we expected to have challenges with that. But in fact, we found that the list was widely viewed as applicable and comprehensive in those two cities. We can't assess whether the same would be true of other cities. But I suspect this list is more or less an adequate representation of what urban services and urban environment improvements might comprise.
Okay, great. I think we have time for one more.
It's a great question. It's a very good question.
Yeah, one more question that I'll share, and then a tack-on question. So Leandra says, just to confirm, the results are from residents of the slums only. It might be interesting to gather a similar perspective from local governments and service providers on what they think are the services that are falling behind. Any thoughts on that? And I'll tack on from Caitlin, what are the next steps?
Okay, that's a great question. To confirm that this study only considered respondents in communities that we defined as slum. We took a broad definition of slum, so that did include extreme slums and much more moderate situations, but certainly we did not include within the study higher income urban residents. And to the question as to whether we assessed prioritizations from technocrats, from urban planners, from people involved in urban investment decision making, we did not, but that's absolutely a question of interest. There are many things which we would do if we could repeat or continue this research. And I absolutely agree, and I think it can be very interesting to assess whether slum dwellers' own assessments of priority are the same as technocrats' assessments, and to be able to identify for which services there are gaps or there are mismatches between the two. I think that's a very interesting question. Thank you.
Great. Thank you so much, Guy, and thank you to all of our presenters. Thank you to you in the audience who attended today. I'll note there are some questions in the chat for Guy and maybe for others that are still out there, so please do revisit those afterwards. Thank you all for coming. The next session is the sponsors exhibition starting in about 8 minutes, and then a half an hour after that is the Young Careers in Virtual Wash, not Careers in Virtual Wash, I hope, Careers in Wash virtual networking event for young professionals. I hope to see you all there. Thank you all.